Mechanism of beta blockers. Effect on heart. 1. Decrease heart rate. Beta blockers bind to beta-1 receptors in the heart, preventing the stimulating effects of adrenaline and noradrenaline. This leads to a slower heart rate, reducing the heart's workload and oxygen demand. 2. Decreased contractility. By blocking beta-1 receptors, beta blockers also diminish the force with which the heart contracts. 3. Decreased conduction. Inhibiting the effect of catecholamines on beta-adrenergic receptors, which reduces the concentration of calcium ions in the cytoplasm and slow conduction through the atrioventricular node. Effect on blood vessels. 4. Vasodilation. Activating postsynaptic beta-2 receptors on vascular smooth muscle cell membranes. Some beta blockers, like carvedilol and labetalol, can cause vasodilation by blocking alpha-1 receptors. 5. Increase nitric oxide bioavailability. Third-generation beta blockers, example, carvedilol, nebivolol, stimulate nitric oxide release from endothelial cells through ATP efflux. Effect on kidney. 6. Renin-angiotensin-aldosterone system inhibition. Beta blockers, particularly non-selective ones, partially block the beta-1 receptors on the juxtaglomerular apparatus in the kidneys. This reduces the release of renin. Renin is a key enzyme in the renin-angiotensin-aldosterone system pathway that ultimately leads to increased blood pressure by causing blood vessel constriction and fluid retention. The above mechanisms produce the following cardiovascular beneficial effects. 1. Decreased blood pressure. 2. Decreased myocardial oxygen demand. 3. Decreased water and salt retention. 4. Decreased oxidative and inflammatory stress. 5. Attenuated cardiovascular remodeling. Mechanism of beta blockers. 1. Beta-adrenoceptors are coupled to G proteins, which activate adenylyl cyclase to form a cyclic AMP from ATP. 2. Increased cyclic AMP activates a cyclic AMP-dependent protein kinase that phosphorylates cell-type calcium channels, which causes increased calcium entry into the cell. 3. Increased calcium entry during action potentials causes enhanced release of calcium by the sarcoplasmic reticulum in the heart. These actions increase inotropy, contractility. 4. G protein activation also increases heart rate, chronotropy, by increasing phase 4A pacemaker currents in the sinoatrial node. 5. Protein kinase phosphorylates sites on the sarcoplasmic reticulum, which leads to enhanced release of calcium through the ranodine receptors, ranodine-sensitive, calcium release channels, associated with the sarcoplasmic reticulum. 6. This provides more calcium for binding thiotroponin C, which enhances inotropy. Finally, protein kinase can phosphorylate myosin light chains, which may contribute to the positive inotropic effect of beta-adrenoceptor stimulation. 7. Because there is some level of sympathetic tone in the heart, beta blockers can reduce sympathetic influences that normally stimulate chronotropy, heart rate, inotropy, contractility, dromatopy, electrical conduction, and lusitropy, relaxation. 8. Therefore, beta blockers cause decreases in heart rate, contractility, conduction velocity, and relaxation rate. These drugs have an even greater effect when there is elevated sympathetic activity. Comparison between beta receptor selective and non-selective. Non-selective beta blockers examples propranolol, nadolol, pindolol, labetalol, penbutalol, sotalol, and carvedilol. They block beta-1 receptors in the heart, thereby inhibiting activation of adenylyl cyclase and subsequent rise in cyclic AMP. As the cyclic AMP levels fall, cyclic AMP-mediated protein kinases are not activated, resulting in the inhibition of contraction. This results in a decrease in both the rate and force of contraction, thereby producing relaxation and reduced cardiac output. This drug also blocks the beta-2 receptors on the smooth muscle in the lungs and again decreases cyclic AMP levels. Here the role of cyclic AMP in smooth muscle is in activating MLCK, thereby producing relaxation. As cyclic AMP levels are decreased by beta blockers, MLCK is not inactivated, instead active and produces contraction. So, Non-selective beta blockers produce cardiac inhibition and smooth muscle stimulation. They produce bronchoconstriction contraindicated patients with asthma and COPD. In the other case, selective beta-1 blockers example atenolol, betaxolol, bisoprolol, ismolol, acebutolol, metoprolol, nebivolol are cardioselective, specifically acting on the heart. Beta-1 blockers work by binding to beta-1 receptor sites and inhibiting the action of hormones like epinephrine and norepinephrine. This blockade results in decreased contractility, decreased heart rate, increased relaxation and decreased cardiac conduction times. As they are selective for beta-1 receptors, they show negligible action and produce less bronchospasm. Disclaimer: this channel does not promote or encourage any illegal activities, and all contents provided by this channel are meant for educational purposes only. Any copyrighted material on these slides is included as fair use for educational purposes only. It will be removed at the request of copyright owners.